Our next speaker is Dr. Amy Paller from Northwestern, who will be speaking about what are the odds genetic counseling for epidermolysis bullosa.
Thanks, Jerry. Let me get that up. Where are we? Well, we're going to shift gears a little bit here, and I'm not going to be talking so much about therapy, but a little bit about some of the usefulness for prenatal diagnosis and pre-implantation diagnosis, and basically give you a course on genetics. And I know you all see a bit about genes and DNA and have probably some different degrees of sophistication, but I would guess don't know that much about genes and the types of genetic tests that we do. So that's what I'm going to try to do over the next period of time. And just remind you, wow, where we come just in the last 15, 20 years in our understanding of genetics. And it all started with a guy named Gregor Mendel, who was a friar, and this was, oh my goodness, not 1965. This was 1865. An interesting typo. And there he is, and what you see here, I don't know, do I have a pointer up here, Jerry? Use the mouse. Okay, here we go. Oh, here we go. That's even easier for me. Okay, so here we have how he did his studies, and he essentially studied peas and noted that there were some traits of peas and how they looked that seemed to dominate, and others that only occasionally showed up, and he devised the concept of a dominant trait and a recessive trait. And I mention that because even though that was quite a long time ago, we still counsel about dominant and recessive traits, as you'll hear now. And then it was in the truly 1953 that Watson talked about the 4 bases of DNA, and we'll be talking about those bases that are aligned within the structure of genes in what's called a triple helix, and it's these various bases that form pairs and line up here with a backbone that helps to maintain that structure that has sugar phosphate in it. So DNA stands for deoxyribose nucleic acid, and this is the sugar, and there's the nucleic acid, or the bases. And there are 4 building blocks in DNA: adenine, guanine, thymine, and cytosine. We also often call this A, G, T, and C. These are known now to be the building blocks of DNA, and here you see how they are arrayed, as I showed you in that other picture, in that helical structure of DNA. And the DNA basically acts as our body's instructional manual. Now, the DNA here is made up in genes, and genes are then aligned within chromosomes, and these chromosomes live within the nucleus of a cell. And from these genes, we have something called mRNA that allows that DNA code to be translated and eventually make the proteins that are so important for everything our body does. Now, when there's a mutation, it basically means that there's a change in this gene that results in no protein or a protein that is abnormal and just doesn't work. And we all know about the Human Genome Project, and we now know that there are about 30,000 genes in humans on our 46 chromosomes, 23 pairs of chromosomes, and that this relatively small number of genes in humans dictates absolutely everything that our body does. Now, when I was in graduate school, and I did graduate work in genetics and did genetic counseling back then as well, we had pictures that looked like this. And I remember that the great excitement at that time, which was in the 1970s, was that we were able to make these karyotypes where we basically stopped the DNA in a certain stage and were able to line these up. And what was exciting is that they had a new technique called banding, where we could actually look at certain areas of these chromosomes much more readily. Well, that was a long time ago, and we've come a long way. It was clear that this was something that was going to help us to find large chromosome abnormalities and rearrangements in chromosomes and things like that. But we really had no idea about how to detect small mutations. And that's where the genetic code and being able to read it comes in. So this is the genetic code. And if you remember these bases, we talked before about some of them. This is how proteins are formed. And proteins are made by a series of what's called amino acids. And these amino acids basically are encoded by these 4 bases that are found here, not in DNA, but in the RNA that's formed by DNA. And uracil is the equivalent of thymine in DNA, but within the RNA. And then we still have the cytosine, adenine, and guanine that we saw in DNA. And as you can see here, each one of these is a code. This is phenylalanine and serine and leucine and proline, et cetera. And these are all amino acid building blocks of protein. And in fact, there are even some codes that say stop. So they stop the protein from forming. And that may be at the end of what's supposed to be normal, or it may be a new code that's introduced because of a mutation that basically tells that protein to stop forming. And that's one of the problems that we can see with EB. So what are some of the common types of mutations? I want you to recognize these names. So there are some mutations that are basically substitutes. There's a replacement of a single base with another base, and reading that code, it can either change the protein by changing the amino acid. That's called a missense mutation. And then there are some where you get to a code that says, stop reading this. And that makes no protein, or makes a highly truncated or cut off protein, and that's called a nonsense mutation. And then there are frame shift mutations. If you remember, each of those amino acids are encoded by a series of 3. So if you no longer have a multiple of 3, you delete 1 or 2 or 5 or 7, or you insert a number that gets you out of sync, then you have a frame shift. And at some point, you're going to basically get to a code that says stop reading. And again, another way to cut off the reading and the expression of that protein. And then you can have splice mutations in which you actually skip part of the gene, but the rest of it's correct. So you often have a shortened product. And there's some others, but those are the common types if you get a DNA result back, or if you hear somebody talking about DNA mutations that you're going to hear about. Now, with respect to EB, the mutations have really just been understood over the last 20 years. And it started with EB simplex, the first report of gene mutations from Eleni Fuchs's lab, and then subsequently, with a lot of work being done by the Wito lab, we learned a lot about junctional EB and dystrophic EB and the genetic mutations that result in those. And then in 1996, for the first time, from Angela Cristiano working with Yoni Wito, was the first DNA-based prenatal diagnosis, in this case with collagen 7 for recessive dystrophic EB. And it's been very exciting for me to be kind of involved in all of some of these pioneering works. And in fact, this first patient was one of my girls who's now a 20-year-old adult with a sister who's a carrier. So as of 2010, 12 genes can be mutated, and if you've heard 11, that's because just this past month in the Journal of Investigative Dermatology, there was a new gene for a rare type of EB that was discovered. So we keep finding out about new things related to EB. Now, what about testing that we can do? Well, there's direct genetic testing. That allows us to confirm or rule out a known or suspected genetic disorder in an infected individual. In an infected individual. And so what we do is we examine DNA, usually from blood, but another source is swabbing vigorously inside the mouth and getting what's called a buccal swab. It's another source of DNA. Really, any kind of tissue can give you DNA. And we look for the presence of mutations. And we use a technique called PCR, for polymerase chain reaction, to markedly increase or amplify the number of pieces of an individual's DNA. So there's enough then to be able to look at the sequence or do other testing that allows one to know if a mutation is there. And just to remind you that there are places within the United States where this testing can be done. There's a wonderful commercial site, GeneDx, that was set up actually by individuals very interested in genetic skin disease, and is able to do all the different testing for EB. But there are also research laboratories, and this is a website where one can look up and see who's actually doing the research on different genetic disorders. And there are many individuals also in Europe who are able to do some of this testing, and it's easier to get some tests than others. What specific types of genetic tests can be useful for families with EB? Well, in addition to the diagnostic testing on an individual, which, by the way, really should only be done after you know, by doing immunomapping and perhaps electron microscopy, what subtype, and ideally if something in particular is missing, before you do a more expensive test like DNA analysis. So this is always very important. But we can do this then through DNA analysis to confirm the diagnosis, to make predictions for the family, and you often want to look at more than one member in a family, depending on what the goal of doing the testing is. Carrier testing on family members then can help us, for example, to know who else in the family has a risk of passing something along, and most importantly, so that parents can make decisions about their family planning. We're going to talk about prenatal testing, and we're going to talk about pre-implantation testing as well. And all of these can be and have been performed for families with EB. So just to run through, I know you're all very aware of the different types of EB, but just to show you EB simplex, which can be either generalized or through a relatively newer classification, localized as the most common forms. And these individuals, just to show you, this is electron microscopy for those of you not familiar with it, and this is the basal cell, the very lowest cell within the epidermis, and the one that does all of the proliferating or growing. And when we have an EB of the simplex type, usually we'll see a split through that basal cell, sometimes with keratin filaments that are very clumped, as you can see here, particularly in those with more severe generalized disorder, but sometimes with a pretty normal array of filaments of keratin here, as we see in the localized. And this is a normal keratin array when seen by immunofluorescence with antibodies that specifically can stain the keratin. And this is what we see in a patient with a more severe form of EB simplex, where we see this kind of dotting or bunching up of the keratin filaments, unable to extend to the very ends of the cells and provide the integrity and the interactions that are required for it. What we have generally in this type is missense mutations in either keratin 5 or keratin 14. Why those two? Because those are the two keratins that are found in the basal cell and form a kind of duplex to provide the structural integrity that's shown here with these keratin tonofilaments. So that's the type of process that we see, and this is usually autosomal dominant. So individuals who have EB simplex usually have an autosomal dominant process with a normal gene from one parent and an abnormal, almost always missense mutation from the other parent, and the parent almost always will show the clinical manifestation. So what is autosomal dominant? And I know some of you know this well, some of you aren't too familiar, so please excuse me if I take some time to just talk about the concept of the family tree. And any genetic counselor, and certainly your physician as well, is going to try to ask about this and construct this. And when you see these trees, we make circles for females, we make squares for males, and here we have a married couple, here we have their offspring, etc. So this helps us to predict the risk And it is then a probability that allows us to move forward, and I'm going to show you how that's done in genetic counseling. This is the type of a family tree that we see with autosomal dominant. Doesn't matter if it's male or female, about equal amounts, and we're going to see it usually in successive generations. So here's a father passing to two daughters. This daughter has a family and passes it to a daughter and a son, with this light blue showing you the affected individuals. Now, how do we know what to predict in terms of prediction for each pregnancy? Because with each pregnancy, with all of these predictions, it's a toss of the dice again. It doesn't matter what your last pregnancy was, it's the same probability each time. And here, if you can imagine an effective father who has one abnormal gene and one normal gene, and a mother who has two normal genes, and we know that each child gets one mother's gene and one father's gene, then we can sort this out and see that there is a 2 out of 4 chance that that missense mutation will go to a child, regardless of whether female or male, and be paired with that normal gene from the mother. So that means that there's a 50% probability with each pregnancy, and that's what we see with autosomal dominant conditions and what a genetic counselor would tell you in a dominant disorder. Now, this is junctional EB, and this, is, as you know, can result from a variety of different genetic mutations in the chains of lamin 332 and collagen 17 in one of the integrin pairs, and that's shown here. These are all components that make up the hemidesmosome. Now, we see a different picture with recessive dystrophic EB, of course, this due to collagen 7, which is a major component of these anchoring fibrils. All of these elements, hemidesmosomes, anchoring fibrils, being important for the adhesion of skin. So junctional EB and recessive dystrophic EB are recessive disorders, which means that these individuals get very little protein or sometimes no protein from the gene that's contributed by either parent. So how do we make predictions about recessive inheritance? Here's the family tree. Remember that light blue means affected. Here we're showing orange as carriers. Carriers will not show any features. So there may be lots of carriers in a family, but we don't see anything unless 2 carriers have a child who is affected. And in fact, unless we did genotyping or genetic analysis, we wouldn't even know that these individuals were all carriers. So let's look again at how that sorts out and see what will come up probability-wise. So here's the carrier father, here's the carrier mother. Remember that you have to have both of these gene changes to have someone who expresses recessive dystrophic EB or junctional EB. So when we sort that out, we find that in fact 25% are going to be affected, shown here. 50% will be carriers, and 25% will not carry any indication of a gene, will not even be a carrier. So 25% probability, again, with each pregnancy, for that baby being affected. Now, there are a few little exceptions to the rules and a few other things to know about that I just want to mention. One is the concept of consanguinity. That means that the parents share genes because they're related. And sometimes parents don't even know that they're related because it can be from a common ancestors 5, 6 generations back and they don't know. We've certainly had some families where we've been able to discover that. But if you have the gene, because you're related, you got a greater risk to inherit the same gene that causes a mutation, and certainly the closer you are in terms of being relatives, the higher risk. The concept of homozygous mutations versus compound heterozygous mutations I also want to mention. So if the gene mutation from the mother is the exact same gene mutation from the father, often happens if you're consanguineous, but again, doesn't necessarily have to be. There are some gene mutations that are more common, especially in certain populations, then that's called a homozygous mutation. Compound heterozygous mutations are when it happens to be in the same gene, but the mutations themselves from mom versus from dad are different, and yet the child gets both. Now let's look at the situation here with dystrophic epidermolysis bullosa. And I think many of you know a lot about this, and you know all the various features of recessive dystrophic EB, from the generalized blistering and scarring and milia to the results of that scarring and the anemia and the tremendous loss of protein, et cetera. In dominant dystrophic EB, we see a somewhat different feature. If we look at an individual site, we can see the same scarring and milia, but of course it's relatively mild, oftentimes just the tops of the hands, sometimes elbows, knees, lower legs, some nail abnormalities, but otherwise just fine, as opposed to the much more devastating situation we can see with recessive dystrophic EB. And the difference is that both are due to changes in type 7 collagen, but they are different types of changes. And here we have a single dose, an autosomal dominant disorder passed from a parent to a child, usually a missense mutation in collagen 7. So remember that a missense mutation changes one amino acid and affects the function of the protein, but does not wipe it out. So we have changes in areas of the protein that are important for function, but we see a much milder problem as a result. Now, what we see in recessive dystrophic is nonsense or frame shift mutations, sometimes a compound heterozygote where you can have a combination of a missense and one of these, but regardless, much, much less, sometimes even no detectable collagen 7. So as a result, we have from both parents that donation, and we know that if you have one of these, a nonsense or a frame shift mutation, so you're only making about 50% of collagen 7. If you're a carrier, no one ever knows until you have a baby that's affected that you have a problem. And that also tells us when we're talking about trying to replenish, let's say through stem cell transplantations. Oh dear, that's my phone. I'm so sorry, I forgot to turn it on. Sorry. That in fact, at least I'm disturbing my own. Okay, at any rate, that tells you that with stem cell transplantation, for example, where you're trying to replenish, you really only have to get to 50% or maybe even less to have a really good result for that child. Okay, so compound heterozygote mutations can lead to a severe recessive disorder in a child of a parent with a mild dominant disorder. And I'm going to show you, we've had several situations like this in which we have a mother or a father who has very mild dominant dystrophic EB. And you know, that's not a big concern. And this individual would be predicted to have a 50% probability with each pregnancy of having a child with dystrophic EB. But sometimes a child is born who has much more severe disease. And here's an example. This was a mom. This was her baby who showed extensive loss of skin at birth and very clearly was getting blisters wherever this baby was touched, went on to have very clear recessive dystrophic EB as a result, and that's because she just happened to marry a carrier who had a mutation that was a nonsense mutation and just had loss of that EB gene. And here's another situation. This was a patient that we followed for years who one day came with his cousin from California who, if you look carefully, has some scarring and milia on the top of the hand, and even though younger, was much bigger than this boy with the recessive dystrophic EB. Their mothers were sisters. Their mothers both had missense mutations that resulted in dominant dystrophic EB, but his father was a carrier for another mutation. So compound heterozygote mutations can happen, and sometimes that is an exception to what we might do in a patient. Also, it's important to recognize that new mutations are common for autosomal dominant forms of EB. So many families come in and say, this is a dominant disorder, but there's no one who has this in my family. And the answer is because new mutations can certainly occur. Someone's always going to be the first. And then that individual will have the risk of 50% with their offspring of passing this on, but there is not necessarily anyone else in the family who would have it. I must tell you that rarely EB simplex can be autosomal recessive. You can have basically wipeout, let's say, of keratin 14. Rarely junctional EB can be autosomal dominant. And there certainly have been several instances now with junctional EB where there's no blistering in an offspring, but because there was a missense mutation in collagen 17 that was passed on to offspring, there are dental changes like we see in junctional EB passed along through that missense mutation, often leading to a dominant situation. Okay, also should mention another exception. Sometimes there's more than one child with a dominant disorder born to the same parents who show nothing, not because of the incredibly low probability of having a spontaneous mutation in two children in that family, but because a parent carries a mutation that's not visible on the skin because it's only in germline cells, and by that I mean the sperm or the egg, perhaps in other tissues where it's not going to be expressed. So if that happens, that's another exception to the rule and can explain why more than one child with a dominant disorder is seen from parents who have nothing that can be visible on their skin. Okay. Now, we would counsel that family that they have a less than 50% chance with each pregnancy of having an affected baby. We can't go much farther than that, but certainly not in the very, very, very low probability of having a child who has a spontaneous mutation in a dominant process. And that's called gonadal mosaicism. And one other rare thing to mention, that you can have two copies or parts of a chromosome from one parent who might be a carrier and no copies from the other parent. This is very rare, but it's called uniparental disomy or uniparental isodisomy, and this can give you a situation where someone is affected with a recessive disorder just because it came from only one parent being a carrier and the other parent is not a carrier. All right, so with all of this in mind, some of which are pretty rare exceptions, genetic counselors will provide a risk estimate for a child. Now, if you know the genetic status of both parents, you know they're both carriers, and the risk estimate is pretty straightforward. It's 25%, right? We talked about that with this autosomal recessive disorder. And if one parent's clearly affected with a dominant disorder, we're going to be at risk of having that same disorder of 50% because that's pretty straightforward. But I will tell you that sometimes we don't have the genetic basis or it's not known in the family, and I'm not going to spend a lot of time on this because this is a little bit complicated, but anybody who took probability in college and who said, oh my gosh, do people really use this? Here's an example where probability is actually really used, where there are formulas to estimate the probability of the mom being a carrier, estimate the probability or know it of the dad being a carrier, and then the probability of having an affected child. And in fact, there's an equation called the Hardy-Weinberg equilibrium equation that is used to calculate the frequency of being a carrier if we know that people who have a double dose of the gene and what that frequency is versus people who have a double dose of the mutant gene. And it can all be plugged in and get you an answer. And I'm not going to spend a lot of time on that, but I'm just going to show you some examples of how genetic counselors will use these kinds of information. So let's say your family who has a baby with a recessive type of problem, and there's a sister, and of course she looks clinically just fine, and you want to know, without necessarily even having the DNA analysis, what her risk would be. So she has a 2/3 chance of being a carrier. Why only 2/3? Because of the fact that we know she's not affected, so we can automatically eliminate the possibility that she has a double dose. So she has 2/3 of chance of being a carrier and 1/3 of chance of not having that gene at all. And the father, presumably unrelated, what's the frequency of being a carrier in the general population of recessive dystrophic EB? And Ellen Fender has published that it's about 1 in 370. So we can then put that into the equation with C being a probability of getting both copies of the mutation if both parents are carriers, being 1/4, and come up with an of this child whose DNA we don't really know, of having a 1 in 2,200 chance. Not as small as in the general population, which we would calculate to be less than 1 in 500,000, but still not a very high probability. So these kinds of probability measurements are done. Now, I showed you a situation, let's say, with mom with dominant dystrophic EB. What's her risk of having a child with recessive dystrophic EB? And this is a kind of calculation where we'd be looking at the risk of marrying somebody who might be a carrier. So A, we know mom is a carrier, so that multiplier is 1. B is the father. What's his chance of being a carrier? It's that of the general population, 1 in 370. And C, probability of getting both copies, 1 in 4. So here we have a risk of about 1 in 1,480. Again, much higher than that in the general population. So risk of passing on dominant dystrophic EB, 50%, and risk of about 1 in 1,500, really low, but it can happen, of having a baby with recessive dystrophic EB. These are all risk and estimates, but really, prenatal diagnosis gives you something much more sure. And fortunately, we have the ability to look at genes and try to not just make estimates, but actually provide information to families. So prenatal diagnosis determines the outcome of the pregnancy with near certainty. Why do I say near certainty? Well, it should be 100%, but there are always the possibility of technical problems that come up or whatever, so we never say 100%. It's helpful for couples to decide whether to continue a pregnancy, if that's an option for that family. And it certainly helps to indicate possible complications that can arise at the birth process so that they can be better anticipated. And in the future, we're not there yet, but in the future it may allow prenatal or extremely early therapy to take place. And I just want to mention some of these techniques. Ideally, we'd have totally non-invasive techniques, and that's available for some. For example, fetal visualization through different ultrasound techniques becoming incredibly sophisticated. Limited value, unfortunately, for EB, but who knows? Maybe we'll even be able to see a blister in the future as these techniques get better. Right now, for example, we can look at the abnormal ears one might see of a junctional EB with pyloric atresia, that sort of thing. Another non-invasive technique that's getting pretty close to being of great value is separating fetal cells well from mom's blood. And that's really going to allow us to do very early DNA analysis in the future. But right now we have some mildly invasive techniques. I will tell you that many years ago, before we had DNA analysis, all babies with EB, if prenatal diagnosis was done, was through taking a skin biopsy of the baby. And that had to be done late enough that you could really see the anatomy, and actually this was done even before we had immunomapping. And we really don't do that anymore. There was, at that time, a 1 to 5% risk of fetal loss, and the spontaneously loss is at about 2 to 3%. What we have now, which much better for the baby's sake, are amniocentesis, which one can collect the shed material, and chorionic villus sampling, where one takes part of the placenta from the baby, and here you can see some chorionic villi. And this can be done at as early as about 9-10 weeks, amniocentesis a little bit later, but early in the pregnancy, very low risk for the fetus. And this material from the baby can then be used to test for DNA, or actually there's been some recent work where some of the proteins can actually be assessed through this. And this just shows you amniocentesis. You go in and collect the amniotic fluid, and chorionic villus sampling, which can be done either transabdominally or through the vaginal area. So this is really useful for the most severe forms of EB, junctional EB, recessive dystrophic EB, and some of the potentially lethal forms of EB simplex, plectin abnormalities, for example, or very rare type lethal acantholytic EB. And it's not something that we would, at this point, unless it was very helpful for therapy, be doing on the milder forms of EB. You formed after a previously affected baby because these are recessive forms, and until a baby comes up, one never knows in the family that it's something that should be done. Important to analyze parents and previously affected siblings for mutation, and very important for us as docs is to make early diagnoses on patients, particularly if it's potentially lethal, so we can get information to families to allow prenatal diagnosis. So this is to help with accurate genetic counseling and also assure the reliability of testing that we analyze other family members if possible. And with a recessive disorder, it's important for us to know, for example, that both parents are carriers or our predictions, as I mentioned, are going to be quite different. And then a variety of molecular genetic techniques are used. That can be a direct mutational analysis. For example, asking, is the sequence of the DNA bases correct? Or there are some other techniques one can do if one knows the mutation where you can just hone into a limited area and look at that without even doing sequencing. For large genes, and collagen 7 is a large gene mutated in dystrophic EB, it's very hard to just sequence because there's a huge number of exons or coding components of the gene that one has to look at. And so it's more common to use an indirect analysis using something called microsatellites, which are closely linked minor changes in the DNA from person to person, or by looking at single nucleotide polymorphisms. Again, polymorphisms are changes in the DNA that we all have that don't really affect the protein. It comes out looking the same. So we always need to check at other regions of the chromosome in doing this type of analysis and compare with the parents and make sure that we're looking at just what we want to be looking at. So prenatal diagnosis techniques can get an answer back within about a week right now for families and allow one to make an early decision in the pregnancy about how the family should be moving forward. And sometimes that decision is to terminate a pregnancy, sometimes that decision, even with an affected child, is to continue the pregnancy, but to be well equipped to manage when the baby is born. For those families who really don't want to risk having a child with EB, but have really no options such as terminating a pregnancy, if that would be considered, there is a technique called pre-implantation genetic diagnosis, and this utilizes in vitro fertilization. So in vitro fertilization, without any person, the egg and the sperm are put together and babies start to be formed on a cellular basis, and these can subsequently be put into a mom to continue to carry the pregnancy. So you can take that early group of cells with just 8 to 12 cells, it's called a blastomere. This is only about 3 days after fertilization. You can take out one cell, extract the DNA from it, amplify it, as we talked about earlier with PCR, decide which of those fertilized, the blastomere, are normal or carry the mutation, and then implant only those normal fertilized eggs. Sounds great, sounds futuristic, but it's actually been done quite a bit for some other genetic disorders, and it has been performed for junctional EB and for some other types of an EB called with ectodermal dysplasia and skin fragility. Now, I will tell you that this is in vitro fertilization, so it doesn't always take. There's about a 25% pregnancy rate per embryo transfer, and it's also not inexpensive. All things to consider. Always has to be checked still by chorionic villus sampling at 10 or 11 weeks gestational age, but this is an option for families. It is only a procedure that's performed at special centers. It may not be possible. Maybe you can't get the eggs or that early embryo. There are technical issues. If you can imagine taking one cell and extracting the DNA and using that as the basis for making decisions, and it's usually not covered by insurance. So it's difficult, and there have not been too many examples of that, but I think there are new advances that are making this technique increasingly feasible, and this will be more of an option in the future. So I've tried to give you an overview of some of the basic information you need to know for interpreting genetic tests, and advise you that we now have the capability of providing counseling based on knowing the subtype of EB first confirmed by immunofluorescence or electron microscopic studies on affected skin, and then ideally by finding the specific mutations, and that by using DNA analysis, prenatal and preimplantation diagnosis can be performed to advise families of risk prenatally, and I thank you for your attention. We're running a little behind. Let me see if there's one or two questions. Yeah.
My youngest son does not have EB, and his girlfriend was asking me, please find out what we can do to find out whether they are carriers for further testing to know.
Is the DNA mutation known in your family?
No.
Okay. So if you want to do that, first thing is to see if you can get it done through GeneDx, and they will help you. Some insurance will cover, some will not. It is not inexpensive testing. Depending on what type you had, there may be some other options internationally to try to get information for your family. The problem with not doing it in the United States, and this came up as a problem for one of our families recently, and I'll actually mention this because it's interesting, is that we have what are called CLIA-approved laboratories for doing genetic testing, and there aren't very many of them. One of them is GeneDx. There are a few other options for that in the country, but GeneDx does the bulk of EB testing. So they're very good. I put up the website, and I'm happy to give it to you again if you didn't catch that, at trying to look into that. You would have to first find out what the mutation is in your family.
So would that entail my husband and I being tested to see who is the carrier?
You have an affected child?
Yes.
So if your child is, I assume, with the recessive process,
yes.
Your child would be the best one to be tested with your information as well to confirm, and then you know what the possibilities are. Then it's if you can get your child tested, it's easier then to hone in and look specifically for those mutations in you, your husband, and your daughter. Your daughter, I think you said it was?
2 boys.
Oh, okay, your son.
So my one son has EB.
The other, okay. So you'd be able to look in the son who's unaffected. The situation, though, would be that his fiancée, they'd be looking at the same gene, but they'd have to start from scratch again and really see the whole gene, looking, because any kind of mutation in the gene doesn't have to be the same one. Remember, the compound heterozygote state could do it. So it's a lot of testing, and I will tell you that most families in that situation just look for probabilities and say, gee, that's a pretty low probability here, and go with that. But if your insurance will cover, I think it's great to know that information, but I think that it's going to be difficult to have all of that done and have true probability. Worth looking into, but I do think in the future, based on all of this, as techniques get much easier and much less expensive, I think we're going to do this on everybody, but we're just not there quite.
Good, thank you.
Got a few questions in the back. Can I take them, Jerry? Is that okay? Okay.
Raise your hand.
While you're passing on the mic, I'll just tell you quickly the situation I was alluding to. We had a patient with a very rare B, and we were able to get the genetic testing done in the Netherlands. We know exactly what the problem is in the family. The Netherlands folks are very happy to do DNA testing so this family can go on and have prenatal diagnosis. The family did not have any kind of insurance, and I have had great difficulty getting our OB gynecologist who would be collecting the material to agree to do this because the DNA analysis would not be performed in a CLIA-approved lab in the United States. Now, one could say, family doesn't care. I mean, they just want to be able to know about this baby, but there are some potential legal issues that could come down the road if there were a mistake, for example, made in that laboratory in the Netherlands. So one can get information sometimes about genetic disorders from labs that are not CLIA approved, that are outside the United States, but there are some potential difficulties in utilizing that information. Yes?
I have one comment and then a question. We had the genetic testing done years ago through Angela Christian's lab when she first started, and we were advised once we found out who was a carrier in the family to not disclose that information for fear that insurance companies might say, okay, you're a carrier, you know, maybe have a pre-existing, not condition, but chance of having a baby with this disorder. So we in our family know who's a carrier in that, but it's hush-hush because of that. And I don't know if it's still that way because this was 15 years ago. But that's my comment. My question is, my daughter, who is RDEB, what are her odds of having a baby? I know it's a matter of meeting, there was a 1 in 370 chance of a man.
Right.
But if you took her, she has the disorder, what are her odds of having a baby with the disorder?
Okay, so we went through that probability, and the A would be 1, and the B would be 1 in 370. So then you have to have a situation, everything that she contributes would be the gene, and he would have it on 1, so you multiply times a half. So it's a pretty low percentage. I don't know if that came out to the 1480 or what. No, it probably wouldn't. Yeah, I'd have to do the math, but it would still be a very low chance. But if it's recessive dystrophic EB, knowing that she's a carrier, the question would be, is there any chance that he's a carrier? And so you'd have to really sequence the whole gene or do some of these other techniques, indirect techniques, to try to look at that to know even what their odds are beyond that very low number. But let me just say that hopefully with some of the new health reform, some of these issues that we've all faced about writing things down in terms of diagnoses on medical records may not be such an issue because of the inability moving forward, I hope, of insurance companies to prevent people from getting their insurance coverage as a result of having a pre-existing condition. Yeah.
Hi, I had a question about the 25% probability. Are you saying that the probability is that they would have the same subtype of EB, or is there a probability they could have a different type? For example, my daughter has junctional EB.
There is pretty much no chance of having another type of EB. You're not at any increased risk of having another type of EB because you have EB or have EB in the family of a different type. The only exception is a situation if you call them different disorders of recessive versus dominant dystrophic EB with that small probability. So let's say somebody has recessive dystrophic EB in the family. There's no increased risk beyond the general population of junctional EB. Each one of these is caused by a different gene being mutated, and there's no greater risk of having an alternative gene being mutated than the general population. Is that what you mean?
Okay, I think I get it, yeah.
Last question in the back.
First, I'd like to say I heard you speak about 2 years ago, and I learned a tremendous amount of information about the genetic side of EB. My son is 7. He has dominant dystrophic EB. We have a daughter who is unaffected that we know of. We don't know if she's a carrier. My husband and I and my son were all tested.
Wait, you said he has dominant dystrophic EB.
He has dominant dystrophic.
Okay, so presumably the mutation in your family, if there's one dose of it.
Well, we actually did the testing through GeneDx.
Okay.
So my husband is the carrier, but he is unaffected.
Okay,
And
well, I didn't get into expressivity because it was a little bit beyond, but I'll make a comment on that.
Well, I just wanted to clarify, because you had said that there's a 2/3 chance that my daughter, who doesn't look like she has EB because she doesn't have any blistering at all, but we've never had her tested. Is it also a 2/3 chance with dominant or recessive?
No, that's if we're talking about a recessive disorder in that particular example. With dominant disease, it depends on the expression and the penetrance of features. So with dominant disorders, there are many examples of variability within families. of how it is expressed, sometimes fairly extensively for a dominant disorder, and sometimes you can barely see it, and it depends on the disorder, but we've had situations with both EB simplex and dominant dystrophy where there are differences among family members suggesting that environment may play a role. And if you think about it in a process like keratin gene changes or collagen 7 gene changes where the environment, perhaps early exposure to trauma, we don't really well understand it, can make a difference, or perhaps the presence of other genes that modify how a gene mutation may be expressed can make a difference. So thank you for bringing that up, because there are situations where there isn't anyone else in the family, but when you do the genotyping, you actually find it. Another reason why it's important to try to get genetic analysis. Okay.
National Rehab's advocacy on behalf of the EB community is part of our commitment to offer patients the wound care products they need and the care they deserve. National Rehab is proud to provide products, information, and support that help EB patients and their families enjoy a better quality of life. If you'd like to learn more, call 1-800-451-6510 or visit our websites, www.nationalrehab.com or www.ebnurse.org.